Yeah, there's actually an increasing recognition of the role of exercise, particularly supervised exercise, in a host of cardiovascular disorders in order to help to improve functional capacity, to improve quality of life, to improve cognitive function. One of the studies that was presented here at this meeting that I was one of the co-senior authors on was to look at changes in fitness levels early in life. So in the Cardia study, exercise testing was performed at an average age of 24, and then again 7 years later. And what we found was that in individuals who had an improvement in their fitness level over the course of that 7 years, simply 1 minute further on a treadmill protocol, for example, there was a 20% reduction in their long-term development of cardiovascular disease and of mortality, actually. So changing fitness levels, which is important advance because, as you can imagine, if you just measure fitness one time kind of cross-sectionally across the population, then you may be reflecting patients' inherent fitness level, their genetic contributions to fitness, and the fact that you can change fitness levels over time, over a period of 7 years early in life, and that can translate to improvements in long-term health outcomes is, I think, an important message in terms of the role of performing exercise on a regular basis. Some of these supervised programs for patients that have heart failure, pulmonary hypertension, can really be helpful in catalyzing regular physical activity that we know translates to better outcomes. I think that it's hard to take somebody who's never performed exercise and then have them start exercising, particularly if their cardiac or pulmonary disease interferes with their exercise capacity. And at the same time, if you have an event, an acute coronary syndrome, for example, that can really serve as a strong impetus to begin to change your lifestyle. I think in rehab has been available for patients that have acute coronary syndromes for a long period of time. I think it's really now moved into more chronic diseases like heart failure, where you have patients that may not have wanted to exercise before, but also have had limited capacity to do so. And one of the things we're really learning is that not only can we learn a great deal about the patient from studying them under the stress of exercise, but also from performing regular exercise. There's no such thing as too little in the way of exercise or too little intensity in order to begin to reap some of the benefits, particularly in chronic disease patients. There are different programs and there's different approaches to exercise exposure. It's actually one of the things that's been a topic of several of the sessions and posters that I was just coming from. It turns out that that interval training with more intense, shorter bouts of exercise can really be very complementary to more traditional endurance activity that somebody may undergo for 15 or 20 or 30 minutes at a time. So interval training has been now shown in everything from animal models to humans with chronic diseases to potentially affect a greater changes in cardiorespiratory fitness. And importantly, changes in cardiorespiratory fitness, as I mentioned before, in terms of during relatively young people, but really across the spectrum of the population, translate to improved outcomes. The reality of it is I work in a lab that's dedicated to studying patients using exercise as kind of a physiologic probe. The real people that do the hard work in rehab tend to be non-physicians. They're the nurses, the physical therapists, people that play a hands-on role with the patients, and their role is incredibly important. I have a role in devising some exercise prescriptions for patients and for, again, using exercise to kind of understand the physiology of a patient. But the rehabs are largely staffed by, it typically is some physician oversight, but by non-physicians, nurses, physical therapists that do really an outstanding job. I think that one of the topics of this meeting that was the initial session that I spoke at was to do a better job of understanding subsets of disease. And in heart failure preserved EF in particular, we keep trying to treat all the patients one way. And what we're learning is we really need to do a better job of parsing the population into smaller bins. And one way to do that is to understand exactly what happens to them when they exert themselves. Because within a population of patients that have heart failure preserved EF, when you exercise them, you find that some have a dominant mechanism of their heart rate doesn't increase as well as it should. Some tend to be limited by their inadequate hemoglobin levels. Some are limited by skeletal muscle